I've already washed my hands and greeted my patient, and we'll go ahead and start off with the external eye exam. So we're going to start off by testing visual acuity, and for this, it's recommended that you have a Snellen eye chart. And for our patients, we like that most cards will have a correct distance listed on the card for how far it should be away from the patient's eye. And in this case, it's about 14 inches. So to test for visual acuity, you have the patient cover one eye. So you can cover one eye for me. Hold the card about 14 inches away from the patient and have them read, what's the lowest line down that you can read?
7943.
Okay. Can you please cover the other eye? And again, what's the lowest line that you can read?
8974, I think that's an 8.
Okay. Very good. If patients are dependent upon glasses, it is preferred that they place the glasses on so that they can read the eye chart first and then try it without glasses on. After checking for visual acuity, we're going to check for visual fields. And for this, you need to be directly in front of your patient, and your instructions to the patient are going to be to cover one eye and then look directly at my nose the entire time. Now, as the examiner, you're going to cover the contralateral eye that the patient is covering, and with the patient looking directly at your nose, you're going to check all 4 visual fields. And I'm going to do that by wiggling my fingers as such. And I want the patient, if you could please tell me when you can see my fingers wiggling. We start from behind the patient's head, out of their field of vision, and then slowly move forward.
Now.
Okay.
Now. Now. Now.
Okay. We'll go ahead and switch eyes. Again, looking directly at my nose the entire time. We'll do the same exam with the other eye.
Now. Now. Now.
Okay, very good. So visual fields are intact. If the patient were unable to see a portion or unable to recognize the movement of my fingers until it reached midline, that would tell me that she has a visual field. Next, I'm going to inspect the external eye, and to do this, I'm going to pull down on the lower lids, examine the conjunctiva, the iris, the pupil. Go ahead and look up for me. We're looking for any nodules, masses. Can you look down? Any injection, any discharge. Look right at me. Okay, and I don't. Next, we'll inspect the cornea of the eye. To do this, you'll stand directly in front of the patient, again asking her to look directly at my nose. And I'm going to shine a light from the patient's side, so perpendicular to her line of sight. I'm looking for any opacities or shading of the cornea. We'll do the same thing on the other side. Next, we will inspect the pupils. So I'm looking directly at the patient, and I'm inspecting the pupils, looking for symmetry and color. We'll then check for direct and consensual reaction to light. So look directly at my nose, and I'm going to shine a light in your eyes. And as I shine the light in her left eye, I expect to see the pupil constrict. As I do it a second time, I'll look at her right eye and make sure that that pupil is constricting as well. Continue looking directly at my nose, and I'll do the same thing with her right eye, checking for direct, and then consensual contraction of the pupils. The next thing I'm going to do is check for extraocular muscle movement. And for this exam, with standing directly in front of the patient, you can ask the patient to follow your finger using just their eyes and not moving their head. So look directly at my finger, and I want you to follow it, just moving your eyes. And with this maneuver, we're checking cranial nerve 3, 4, and 6. After you've completed checking for extraocular muscle movement, we'll check for convergence. And so continue looking at my finger. Okay. The next part of the exam is doing a fundoscopic exam. And I'll go through the motions of this exam, but realize that for a complete exam, the eyes likely need to be dilated and the room needs to be dimly lit. For this exam, we'll use the ophthalmoscope. When using the ophthalmoscope, you first need to figure out the correct lens to use for your vision. And so to do this, I usually look through the ophthalmoscope at my own hand and turn the lenses until I can see the grooves on the palm of my hand. Once I've done that, I know that the lenses are corrected for my vision, and then I can look into the patient's eyes. First, we will look for a red reflex, and to do this, you look through the ophthalmoscope from usually a distance of about 12 inches. So with the patient picking out a spot on the wall and continuing to look there the entire time, I'll shine the light in their eyes, and I'm looking at the red reflex right now. After finding the red reflex, I will move in using my left eye to look into using my right eye to look into the patient's right eye. And getting close enough, I'll be able to start making out structures on the retina. After examining the optic disc and its structures, I'll ask the patient to look directly into the light, and very quickly I'll look at the macula, and that will complete the internal exam for the patient's right eye. We'll then move to the left eye, again looking through the ophthalmoscope with my left eye to examine the patient's left eye. And from a distance of about 12 inches, we'll go ahead and look directly into the eye with the patient still looking at the area on the wall that they had picked out, and I'm looking for the red reflex. Having found the red reflex, I'll then start moving in to examine the retina of the patient. And I'm looking at the optic disc and its structures, and then I'll quickly ask the patient to look directly into the light, and that allows me to focus on the macula. And that's the end of the eye exam.